Hi, I'm Jane Marks, and this is From the Heart. As you know, each week we cover topics that impact teens and their families. Well, this week is no exception. Today we have joining us two very phenomenal women, Dr. Alma Littles and Dr. Sunitha Strong. Dr. Littles is currently the Senior Associate Dean for the Florida State College of Medicine. She has more than 35 years of experience in her role as an expert on patient care and access to health care. She is also a leader in organized medicine and a longtime patient advocate. Dr. Strong is a family medicine specialist with over 30 years of experience and also works at the College of Medicine at Florida State University. Like Dr. Littles, she is also a fierce advocate for patients. Thank you, ladies, for joining us today. We're so happy to have you. Dr. Little, we're going to start with you. And I want you to tell us a little bit about your role at the College of Medicine and what this is going to mean to so many teens across the country.
Sure. Well, thank you for having me. I am, as you said, the Senior Associate Dean for Medical Education and Academic Affairs at the College of Medicine. So I serve as the college's Chief Academic Officer, which means I oversee the medical education program for the 4 years of our medical students' education. And within academic affairs, we also have our graduate medical education program where we oversee some of the residency training programs in the state. So, you know, we train physicians, and bringing in young people into the program is very important to us. And we see the importance of starting that out early on and having students get prepared.
From my understanding, and Dr. Strong, you can chime in on this, is that there is a real push to include students of color, and that's one of the things that's been amazing to me about this particular program. Is that correct?
Absolutely. You want to start, and I'll can.
Sure. The medical school has a mission that includes increasing the number of underrepresented minorities and also focusing on rural health and geriatric populations. So part of the reason the legislature formed the medical school was to reach out to communities that were underserved already.
Underserved. Now, what's interesting to me about underserved is that both of you have strong passions about the underserved. Is there a reason for that?
Well, we are both from Quincy, Florida, and even though...
And you might say that again, Quincy, Florida. This is a very small town.
Quincy, Florida, which is about 25 miles west of Tallahassee.
Which is the state capital, right.
Exactly, the capital of Florida. And we didn't know each other growing up. I actually met Dr. Little when she was in medical school and I was in undergrad as an aspiring medical student, but I had heard of her even before then from our hometown because she was a legend.
She was like the rock star.
Yes, and so I went to University of Florida and I understood she was already there. So they kept saying, you must look up Alma Brown, which was her maiden name back then. And of course I got to school and I didn't look her up right away, but I ended up running into her then boyfriend, now husband, who says, oh, you want to go to medical school? You must meet my girlfriend, Dr. Alma Littles. I was like, it must be a sign. So I met her, and the rest, as they say, is history. And she's been an amazing friend and mentor for all those years. And so we were actually in practice together early on back in Quincy.
Now let me just stop you, because when you talk about practice, you started the practice first. Is that correct?
That's correct.
This was a general family practice?
Yes, general family practice.
Okay, so there weren't specialties, because you mentioned geriatrics. So it was just a general family practice, and this was back in Quincy, this small rural town.
Correct. And in family medicine, we take care of all ages, from infants to the geriatric population. So certainly had geriatric age patients in the practice, there at the time.
Now, I'm curious about something. How long was this practice in this small area? I mean, because you've pivoted to the medical school, but how long were you in the rural community itself?
So I was there about 7.5 years in practice there. 5 of those years I was in solo practice before Dr. Strong and some others joined the practice.
Like the power of
Yeah.
sisterhood. Go ahead.
Yeah, yeah. And so I was fortunate enough to be able to recruit Dr. Strong to come back to Quincy to join me in the practice there. We both did our residency training here in Tallahassee as well. So after medical school, she's a few years behind me. So
Just a few.
just a few. And when she was a resident, I was actually doing some precepting of residents in my practice in Quincy.
So for
there.
those people who don't know what precepting means, I think a lot of teenagers looking at this today, what does that mean, for potential students coming into a program?
Sure. So it's teaching. Basically, precepting is teaching. So we bring students or residents or other trainees into the practice to show them how the practice is run, both from the patient care perspective, but also from the business side of how a practice is run. And so part of the training in residency is going into practices in the community and seeing how doctors run those practices.
And I think that's important to note that we're talking about going and doing, boots on the ground, going into these practices in rural communities and really not only just seeing patients, but understanding what their space and place and their families is. That's got to be a very different practice than certainly what you're seeing in medical school.
So the community practice is different. We have we have a practice that's affiliated with the medical school. Here, most medical schools do, and in fact, that's the primary role Dr. Strong plays at the College of Medicine, is seeing patients in that practice. We also have other physicians in the community who our students train with as medical students. But that ability to be able to leave the walls of the primary medical school and go out into what we call the real world.
Absolutely.
And see the practice of medicine as it's being practiced real time outside of the classroom is an important aspect of medical education.
A very important aspect. I think, as we dive deep into this conversation, I think students who are interested in medical school and going forward, there are some real life lessons for you to learn. So I want you to stay tuned. We'll be right back. Welcome back. Today's topics are so compelling for small town communities. And, not only has the focus been on small town communities, but with the pandemic still on the forefront of the news on a daily basis, how has this changed how you are training medical students coming into, having an idea that they were going to be doing one thing, but looking at an entirely different, landscape?
So one of the things is that students need to understand that there's a lot of flexibility required in the practice of medicine, because patients may come into you with one thing that they think is going on, and part of your role is to sort it all out and figure out what's really going on with that patient. And that's the way it is with patient care in general. So we've all had to do some shifting during this pandemic in terms of the way we practice medicine. And so the skill that we try to instill in our students is to have that ability to meet the patient where they are, and then help figure out what the next steps are going to be. So with the pandemic, a lot of the encounters changed to telehealth encounters. A lot of the education, the way we were providing education, changed from face-to-face in classrooms to online as much as possible. Obviously, with the practice of medicine, at some point, if you're going to learn to be a doctor, you got to touch a patient and be in the presence of patients.
Right.
So we had to shift the way we did that, but we were able to get our students back, even though we pulled them out of the clinical setting initially. We were able to get them back, into hospitals and doctors' offices pretty quickly after the pandemic started.
What's interesting to me is healthcare workers across the country are exhausted, and they continue to be exhausted. How do you factor that when you're working with students?
I think having worked nearly every day since the start of the pandemic in the practice setting, I think that you are correct that healthcare workers, including myself, are exhausted. The most important thing with students is to think about the big picture And so I try to exemplify balance, that it is important to take care of myself as well as taking care of the patient. But I also want the student to see the big picture about why we do what we do. I'm a huge advocate of making sure that our community has vaccine available, making sure that they have good information about why this is important. And I want students to know that this is part of what we do. Preventative in the form of vaccination, treatment in the form of taking care of folks who are sick, and we take care of folks who are sick in every arena. We don't forget about heart attacks and strokes and blood pressure while we're dealing with COVID. We have to take care of it all at the same time. But whenever you get stressed, it's important to go back to your first love. What made you decide to go into medicine, and keep that at the forefront in the difficult time.
You know, this is a heartfelt conversation on commitment to medicine. Have you felt like this all of your life? Of course, now you're in a different role. You're in an administrative role, but when it comes to patient care, is your heart still there, or because of what's been going on last year, do you feel burnt out?
So my heart is still there. That passion for taking care of patients and being there for patients and making sure that they're getting their needs met and what they need from the medical community, that is all definitely still there. And so the way that I exercise that passion now is through my students, and as I'm participating in teaching students and arranging activities and arranging experience for the medical students there. That passion of always saying, the patient, look at the patient in front of you. That's what's important, here, and the joy of being able to help them through those difficult times, or even prepare them for those difficult times. Dr. Strong talked about prevention, and talking to them about, I would be much happier if you never got diabetes, if you followed all the preventive measures to prevent it. There, certainly want to be there to take care of it if you end up with that. But if we can prevent it, that's even more significant and important. So yes, that passion is definitely there.
Yeah, it's interesting because I'm thinking about, again, both of you still being from a rural community, and you use the term diabetes, and I think there are certain conditions that I think are seen more in rural communities because of the lack of access to medical care. So when we come back, we want to talk about that and so much of what you're serving. Stay tuned. Welcome back. Well, we are talking about very, very important information when it comes to small communities. And Quincy, like so many communities in this country, is a very small community with limited health care. So tell us a little bit about that and what this means to other communities across the country.
Sure. So Quincy is, as we said, a small rural town right outside of Tallahassee, which is the capital of Florida. Quincy has about 8,000 people in a very rural county that has about 40,000, but the county is quite large in land, just doesn't have a lot of people. There with it is predominantly African American there, and it really is, one of those towns of haves and have-nots there, and a lot of have-nots. Many times, while we have some physicians in the county delivering care, a lot of the specialty care has to be done outside of the area, so patients have to travel for that. Major hospital care is outside of the county, so patients have to travel for that. And so when you've got patients who are resource challenged, even something simple as transportation to get out of Quincy to Tallahassee to the physician becomes a major issue.
When you have your new students come in, are they excited about the idea of going into these small rural communities, or are they just happy just to be in medical school?
Well, I think the medical students that we have at Florida State College of Medicine are excited about the mission. And that's because the admission committee, I used to sit on the commission for a number of years, makes a special point of choosing people that are already passionate about helping to improve in those areas. So we often question, are they a good mission fit? So to get admitted to medical school at FSU, you really do have to have an interest in serving communities that are underserved and minority and elderly and rural. And
You know, something just occurred to me, and that is that a lot of the students coming into medical school do not have the experience in terms of working with populations of color. How do you train them? Let's say you have someone come from a very sophisticated area, let's say in New York, coming to medical school here, very interested in rural work, but certainly not familiar with the culture or the people there. Is there hands-on teaching, for these students to say, rather than just, do you throw them in the pool, or do you say, these are some things that are going to help you navigate this?
So we actually build it into our curriculum. So we actually have training sites in rural areas where students train in those areas so that they get the exposure, to patients. And as I said, cultures across the board, and that training of, you can't just assume, when you go into the room with the patient, don't make assumptions.
Right.
And engage the patient in the conversation before you just assume things about them. Ask them the questions and have them, give you the answers from their perspective.
Do you ever find yourself talking to the patients themselves? I mean, because obviously the two of you are really skilled at this. So let us say I am coming from a small community and I see the doctors and I don't trust them. I don't know that they're going to understand me. What specific questions can I ask them that's going to give me more comfort that they're with me, or that they hear me, or that they're listening to me?
When we train our students, when you enter the room with the patient, first you introduce yourself, and you let the patient know who you are and what your purpose is there, and then you ask the patient for their name, and then
something as simple as that.
Right, as simple as that. But then you also ask, how would you like to be addressed, as opposed to just assuming that I can just walk in the room and say, "Hi, Jane." I ask you, how would you prefer to be addressed? Because Mrs. Marks might be your preferred way of being addressed. And so establishing that rapport up front to build that comfort with having that conversation with the physician once you're in the room.
And while we began talking about medical school and access, what we're learning is not only about access, but how to be good patients as well. Stay tuned, we'll be right back. Before we finish today's show, and because I've been in the mental health field for so long, I would be really remiss if I didn't talk about the connection between medical care and mental health issues. So, Dr. Strong, let's start with you. I mean, how does that fit into the big picture when it comes to patient care?
well, it's often said that when America gets a cold, Black America gets pneumonia. And so mental health is no exception to that. I tell folks that I grew up in a family that was not psychologically sophisticated. That means that when I got to medical school, I'd never even heard of depression. I said, what? Someone feels so badly they can't go to work, can't get out of bed? I just couldn't even believe it existed. And I think so the mental health is one that we often have not had access to or the luxury of. So medical care is a disparity, but so is mental health. And so part of being a family physician and taking care of the whole person, I often think about what is at the root of it. And we find that being stressed and depressed, working 2 jobs, overwhelmed, worried about the safety of your family, all play a role in why is your blood pressure so high. Not being worried about making ends meet, has a role in why your diabetes is out of control and why you don't get enough sleep at night. And so it all kind of comes together about overall wellness. And so taking care of people means taking care of them mind, body, and spirit.
Thank you so much for joining us today. It's been a great show. We have two phenomenal women who started out talking about medical school and access to medical care in rural communities. But we dived into so much more. We talked about cultural competence. We talked about mental health. We talked about patient advocacy. All of these are important to you and yours. We want you to stay tuned. We'll be back next week.